Hi, I'm Dr. Scott Lee. People ask me all the time, they're very confused. They say, I don't really understand why my AFib seems to be worse now than it was a few years ago. It feels like I'm going into it more, or my episodes are lasting longer. Other people will say, I'm on a drug to keep it asleep, but it doesn't seem to be working anymore. After a few years, it just stopped working. Or you get all the people who've had AFib ablations and they say, I don't really understand. I had one AFib ablation, it worked great. But I know a friend who had 3 and it didn't work. I'm kind of confused. Why does the ablation sometimes work with 1? Sometimes it takes 3. Sometimes even after 3 or 4 ablations, there's a person still in AFib. What explains all of this? So this has to do with stages of atrial fibrillation progression. And unfortunately, as important as this topic is, it's actually not talked about much, and doctors just don't really talk about it. Or if they try to identify your stage of AFib progression, a lot of regular cardiologists get that wrong. So we need to clear this up. What does it mean to have a stage of AFib progression? What does that mean to say, what's my AFib progression stage? Well, remember, we talk about how AFib is an abnormal source cells or triggers in the walls of your heart that form, and they actually can sleep and do nothing or randomly wake up, take over control of your heart away from your normal source, and make your heart go faster. And then at some point, it can get tired of being awake, go back to sleep, and then your normal rhythm takes back over control. So it's always a question of, when am I in the abnormal rhythm? When am I back in my normal rhythm? If I'm in the abnormal rhythm, my heart rate can go fast, I can feel lousy, I can have symptoms, I can have risk of stroke if it's AFib. If I'm back in my normal rhythm, I feel fine, everything's good. So this is the abnormal rhythm. But unlike other abnormal heart rhythms, AFib tends to be a progressive rhythm problem. AFib sources progress as you get older. See, when you talk about these abnormal cells developing the walls of the heart, people say, well, why did I even get these cells? You develop these AFib cells because over time, your heart walls underwent stretch and inflammation. Those are the 2 key things that cause AFib sources or cells to form: stretch and inflammation. And there's lots of things that cause stretch and inflammation: high blood pressure, sleep apnea, being overweight, diabetes, rheumatoid arthritis, chronic kidney disease, highly processed foods, junk food diet, alcohol, smoking. There's a whole host of things. Aging alone causes a certain amount of stretching and inflammation of your heart, even without the other medical problems. And as you get older, whatever risk factors you have that are causing AFib cells just progress. So as you get older, we do see AFib get worse. This is something about AFib that people don't always understand. This is why your AFib gets worse. It actually progresses. So you need to think of AFib as more like being a little forest fire that's constantly but slowly getting bigger and worse inside the walls of your heart. If you think about the walls of your heart as being like the forest and the AFib cells as being like a little forest fire, well then year after year, once you develop the AFib and have this diagnosis of AFib, every year you get older, you're forming a little bit more AFib cells. And as your forest fire gets bigger and spreads to more walls of the heart, or more walls of the forest, so to speak, guess what? You have more AFib cells total. These cells are stronger. They want to wake up more. They want to go to sleep less. And you end up spending more time in AFib as this progresses. So you need to think about AFib as not being a static thing, but being a progressive underlying problem. So there are actually stages to AFib, like early, middle, late, permanent, just like there are stages to a forest fire, just like there are stages to blocked heart arteries. We don't just say everybody has mild blocked heart arteries. Somebody can have a mild blockage, a moderate blockage, a severe blockage, or 100% blockage, 100% occlusion. Same kind of thing with AFib. There are progressive stages. Now, in the early stages of AFib, you don't have that many AFib cells. Out of the 6 walls of the left atrium where AFib cells form, it always starts on the first wall, the back wall, actually in the corners of the back walls, right where these little veins called the pulmonary veins insert into the 4 corners, and that's always where AFib starts. That's actually why the standard ablation approach, this simple one-wall ablation we talk about in other videos, is cauterizing in those 4 corners. Very simple, but effective in early stages, not so much in later stages. But every year you get older, your AFib can progress. Not necessarily in everyone, but for the vast majority it tends to. And as you're forming more AFib cells, now it spreads from the corners of the first wall to the middle of the first wall, and it fills that up. And guess what? When it fills up the first wall, it can spread to wall number 2, the sidewall. When you have 2 out of the 6 walls filled with AFib cells, that's a bigger forest fire. You have twice as many cells. That means they're going to want to wake up twice as much and go to sleep twice less often. So guess what? You're going to be in AFib more. It's going to wake up more. Maybe when you only had it on 1 wall, you were in it 5 or 10% of the time. When you have it on 2 walls, you might be in it 20 to 30% of the time. It wakes up more because you have more sources or cells of AFib. It's progressed. When it spreads to 3 walls out of the heart, 3 out of the 6 walls, now you're at a middle stage of AFib. Maybe it's waking up 40 or 50% of the time. When it spreads to 4 walls, now you're having it wake up 60 or 70% of the time. You could actually be in AFib more than you're not. When it spreads to 5 out of the 6 walls, now you're at late stage AFib. You're in it 70, 80% of the time. Now, when it finally spreads to all 6 walls, you're at a very late stage of AFib. Maybe you're in it 90 to 100% of the time. And that's the late stage. So at that point, there's still one last stage you can get to. That's permanent AFib stage. That's where you're in it 100% of the time. You have it on all 6 walls. And now it spends another 3 to 5 years progressing to cover every inch of all 6 walls, not just be on all 6 walls. And at that point, you've been in AFib so long, 100%, it becomes so chronic, so ingrained, like a forest fire that's covered the entire forest that you can't put out anymore. And that's permanent AFib. That's the last stage. And that's where you're in AFib 100%. You've been that way for years. We cannot get you out of it, whether with a medication or an advanced ablation. Nothing gets you out. Even shocking it won't work. And you just live with it for the rest of your life. But remember, AFib is not a directly life-threatening rhythm problem. As long as you don't have a clot and a stroke and your heart is otherwise strong, you could do well in AFib long-term, although we would have to try to treat your symptoms still, and we have less options once it's permanent. So this is kind of the underlying progression of atrial fibrillation. It's actually more like a continuum. I mean, we put these artificial early, middle, late stages on it, but it's a continuum. You could have early, mid-early, late early stage to early, mid, mid-mid, late mid, and so on. So this is how the progression of AFib works. Now, officially, we actually have terms, medical terms that define these early, mid, late stages. And this is a clinical diagnosis. This is not, oh, I have to go in there during an ablation and see how many AFib cells there are and to know what stage you're at. No, we can clinically diagnose your stage. This is based on your history and how much time you're spending in AFib. If you believe that AFib wakes up more, the more progressed it is and the more AFib cells you have and the more walls it's covering, and there's a general correlation, then this is a clinically diagnosable stage issue. So the official classifications for the stages are: early stage is called paroxysmal atrial fibrillation. Paroxysmal atrial fibrillation. So this is defined as you going in and out of AFib on your own, not having to be forcing it to sleep with a electrical shock cardioversion or an ablation. And the AFib isn't strong enough to just stay awake completely. It's coming and going. And your episodes are lasting hours to days. Officially, anything less than 7 days episodes, you're still classified as early stage or paroxysmal atrial fibrillation. Mid stage would be called persistent atrial fibrillation. This is where you're going into AFib and your episodes are lasting for weeks at a time. You're spending a good amount of time, probably 50, 60, 70, 80% of the time in AFib. And you may still come out of it a little bit, but you're mostly in it. The late stage of atrial fibrillation is called long-standing persistent atrial fibrillation. Now, officially, this is defined as somebody who's reached the middle stage, once again, defined as their episodes of AFib last longer than a week, several weeks at a time, they're mostly in it. They're already in the middle stage, and now they've been that way for more than a year. So you're already middle stage, now you're more than a year or so, you're actually entering the late stage. Now, these people are usually mostly in AFib. They may be in it 100% of the time, but this is the late stage. And then lastly, the permanent stage is once you reach the late stage, where you've been in the persistent middle stage for over a year, you're mostly in it. At that point, 3 to 5 years later, on average, that's where you usually become permanent. That's usually defined as, now I've been in AFib 100%, I have AFib cells on all 6 walls, and now I've been this way for 3 to 5 years. And at that point, usually the AFib cells just keep on forming on all 6 walls until they cover every inch of all 6 walls, these sources or cells. And now your AFib is so chronic and strong, as I said before, that's when you're in AFib 100% of the time. You've been that way for years, and we can no longer get you out of the AFib. The strongest antiarrhythmic drug to put it to sleep won't work. Even the few of us who do very advanced ablations, because not every electrophysiologist does advanced ablations, can get rid of it. and even shocking it won't put it back to sleep for even more than a couple seconds. So at that point, you won't necessarily die from atrial fibrillation. AFib is not directly life-threatening as long as you don't have a clot and a stroke from it. But if you're having a lot of symptoms by being in AFib 100% of the time, we don't have as many ways to treat it. We cannot put it to sleep with a drug. We cannot get rid of it with an ablation. The best we can do is just slow it down with a rate controlling medication to a level where you just can tolerate it and say that's the best we can do. So those are kind of the 3 stages. Now, why is this important? Why is this not talked about more? It should be, because your stage of AFib is like diagnosing how progressed your problem is. It'd be the same thing as saying, well, if I have cancer, don't I want to know if I have a late stage of cancer or an early stage of cancer? That makes a huge difference in terms of how you treat it. Same thing here. If you're at an early stage of AFib, paroxysmal AFib, where it's coming and going, then that's a lot easier to treat or to keep you in normal rhythm. If I want to use an antiarrhythmic drug to put the AFib cells to sleep, out of the 5 drugs I have, I can use a weaker one, and it's probably still going to work because you don't have that many AFib cells and they're not that strong yet. And as you progress through the stages and the AFib gets stronger, it will fail these earlier stage drugs, and we have to go to stronger and stronger drugs to try to keep it temporarily asleep. But that's how you know what type of drug to use and what strength level based on your stage. That's why sometimes when doctors don't understand this concept and they don't understand the different stages of AFib or the different strength levels of these antiarrhythmic drugs, they're just willy-nilly, oh, I'll stick them on this antiarrhythmic drug. Oh, it doesn't seem to work, I'll stick on this one. It just seems random, but it shouldn't be random. It should be, I have this level of AFib, let me use a drug that's stronger than that. Oh, it got stronger over several years and it's breaking through that drug, let me go to a stronger one. There is a hierarchy of strength, and when used properly, it can work very effectively. If you are having an ablation, remember, ablation is not just hit or miss, and sometimes it works and sometimes it doesn't. One friend had 1 and one friend had 3. It sounds like it's hit or miss. It sounds like it's random, but it really isn't. It has to do with stage. The 3 main determinants of AFib ablation success are: number 1, what stage of AFib are you in? How big is your forest fire? If you only have AFib on that first wall, the pulmonary veins, the 4 corners, you're at a very early stage. You don't need a very complex ablation to get rid of your AFib. If you undergo a standardized, simple one-wall pulmonary vein isolation, we call that, to get rid of the corners of the first wall, which every electrophysiologist can do coming out of training, you'll have a 70 to 80% success rate. The problem here is, what if you're at a later stage? What if you have 2 to 3 to 4 walls and you're in a middle stage? What if you have 4 to 5 to 6 areas, what we call non-pulmonary vein triggers? This is where you have these AFib cells or sources in other areas of the heart, not just that first wall. Well, then guess what? You're going to need a more advanced ablation to get rid of it. If you do a simple one-wall ablation and somebody has 3 walls worth of AFib sources, how are you going to get rid of it? You're still leaving 2 walls worth. That's why the success rate for standard one-wall ablation or pulmonary vein isolation drops from 70 to 80% to 40% once you're in the middle stage. And then once you're in the late stage, where most of the walls are filled with these AFib cells or sources, the success rate doing a one-wall ablation drops to 20 to 30%, which is almost nothing. So it makes a big difference as to how big your forest fire is, what stage you're at. And then number 2 determinant of AFib ablation success is, if you are at a later stage, is your electrophysiologist capable or have the skills to do a more advanced ablation to match your stage? If you have a big forest fire, do you have a firefighter who has the skills to do and put out a more advanced forest fire, or are they just do simple forest fires? It's kind of the same analogy. So those are the 2 main determinants. And that's why you see people have multiple ablations and still not get the result. It's because they have a more advanced stage of AFib and they're going to somebody who does simple one-wall ablations, like taking a 50% forest fire and getting rid of 10%, you're just not going to get the result. And that's what explains that. And then of course, a distant third determinant is the energy source. That's the least important, because whether you cauterize or freeze or use pulses of electricity with the newest pulse field ablation technology, it's just a way to destroy the cells. The skill of the operator and what they're able to do and how complex of a lesion set and how many walls they can go after and how many sources, combined with how big your forest fire is, are the real determinants. Easy is easy and hard is hard. If you have a small, early stage forest fire, who can't put that out? It's easy. Somebody who's fresh out of training can probably put that out. Just takes them longer. If you have a late stage forest fire, not everyone may have the skill to do that. That's where hard is hard, and finding somebody who have a good chance of getting rid of your late stage because they have more advanced skills could mean the difference between 3 to 5 ablations versus 1 or 2. So stage is ultimately the most important factor to know about your AFib because you want to know whether you're at a later stage and treatments are going to be harder. You want to know if you're at an earlier stage where treatment's easier, you could use a weaker antiarrhythmic drug or do a more simple ablation, and you're going to have less symptoms to begin with because you're just not in it that much. And this is also the paradox, which is if you're at an early stage and all the treatments are very effective for you because you're at such an early stage, but that's also the stage where you don't have a lot of symptoms. You're not in AFib very much. And you might go, I'll just tolerate it. But then when it gets worse, and now you're in it all the time, and now you want treatment, but now treatments are harder. So you have to understand this. It's also at the earlier stages where those triggers, the things that wake it up, like, I drink some coffee or alcohol, or when I exercise or when I sleep, the different types of triggers, they make more of a difference. When you're at a later stage AFib and you're in it most of the time, you're already in it most of the time. You can't really wake it up more if it's already awake, doesn't really matter anymore. Now the triggers matter less. Now it's the treatments. So understanding your stage of AFib is probably the most important thing you can do. And unfortunately, this isn't really understood very well. And a lot of doctors, especially regular cardiologists, they just label everything early stage paroxysmal AFib. You could have somebody who's permanently in AFib, and sometimes you'll see a note that says paroxysmal AFib because they just don't really understand this. But you as a patient should understand this so you understand why certain things work and why certain things don't. So I hope this was helpful. If you found this useful, please subscribe. And if you wish to have more resources, including a quiz that can actually help determine your stage of AFib progression by inputting what medicines you're on and how often you go in and out of AFib, you can find that on my website, drscottlee.com. And if you wish to book a second opinion clarity consult with me, that can also be found there. I'm Dr. Scott Lee. I hope you found this helpful and realize that knowing your stage of AFib is probably the single best piece of information you can have to understand what best ways to treat your AFib is. For everything atrial fibrillation related, please feel free to go to my website, drscottlee.com, where you're going to find more resources and also can follow me on social media.